of talking about infant formulas, which generally weren't covered much here. So I think that as important as much as we value breast milk and human milk, that we do need to discuss the use of infant formulas and consider them a little bit and how we can use them. As others have said, my email, my correo electrónico is here. Feel free to email me, and I'll be glad to try to answer your questions. La siguiente, por favor. When we talk about infant formula, I think the first things that we need to talk about are safety issues. And I want to present this case study because I think it was probably the most important recent example in which the use of infant formula led to a bad outcome. And it's important to remind us of the risks associated with infant formula. Now, as I tell about this story and remind you about the safety aspects of infant formula, it's certainly true that the overwhelming majority of babies do not have a bad outcome from infant formula, and that there's a lot of things in place, as we'll talk about, to protect infants who receive infant formula and to make sure that it's generally safe. However, I think this case and this example needs to be discussed. In October of 2003, 3 babies were hospitalized in Israel within a week of each other with encephalopathy. Another baby was admitted shortly thereafter with varying symptoms of nystagmus and vomiting. The infants were treated with thiamine and improved within hours. An investigation was done and a lot of work was done, and ultimately it turned out that the infants had all received the same soy-based infant formula, and that this use of this formula resulted in several deaths and numerous hospitalizations. Investigation demonstrated the formula was deficient in thiamine, a very, very uncommon deficit, leading to these symptoms and the death of the infants. La siguiente, por favor. In the United States, the content and the quality of infant formula is regulated by the Food and Drug Administration, and there are very specific guidelines for that. And I know that each country in general around the world has its own set of guidelines that may be based on FDA guidelines or may be unique. In the United States, the FDA guidelines specify minimum amounts for 29 nutrients and maximum amounts for 9 of these nutrients. Now, something interesting about this is that there's much more control on the low end than there is on the high end. And that makes sense because we want to make sure the babies get the minimum amount of nutrients like calcium, phosphorus, thiamine that we know they need. But there's a lot less control on the high end. And if you actually go out and analyze batches of formula, which we do sometimes, we can discover that the levels of nutrients like zinc can be 50% higher than what's on the label. And in fact, that those nutrients are generally not tightly regulated and tightly monitored. Because infant formulas must meet the minimum that's on the label, it's generally manufacturing practice to put a level of nutrients in them that's about 5 to 10% higher than that minimum, and that's almost always seen when we analyze batches. So again, going back to what we tell residents and things, when we calculate nutrient intakes and we imagine that the baby's getting 115 calories per kilo per day, in fact, we're basing that on the label claim, not taking into account the actual content in the formula, as well as any losses that may occur during tube feeding and things like that. So these are all just estimates. La siguiente, por favor. There are specific guidelines for the manufacture of formulas I talked about. And if a formula does not meet those guidelines, it's considered an adulterated product unless the formula has a special exemption. Yesterday I talked about a renal formula called PM6040, which has low levels of calcium, phosphorus, and other minerals. It's a special formula that's exempt from the guidelines. Manufacturers have to analyze representative samples for the nutrients that they're required to analyze every 3 months. And then it gets tricky. The manufacturers have to notify the Food and Drug Administration whenever they change the formulation. This is a complicated process, and a lot of proposed guidelines are in place. In general, if the change in an infant formula is small, then the FDA will not require extensive research into it. If this change in the formula is major, let's say an entirely new protein source or method of preparing the protein, then the FDA may require an entire new set of growth data, which are very expensive to do. So there's a lot of back and forth on that type of issue. There's a proposed analysis called the decision tree analysis that was proposed in 2004 to kind of decide how to go about evaluating new formulas. I can tell you that that has not been implemented as of today. We're still in a situation where there's a lot of haziness and unclarity between the FDA and formula manufacturers about new products. La siguiente. I'm going to give you an example that I just ran across on the internet recently because this was an example that I thought was really very interesting to me. I've done a lot of research and I'm interested in the concept of prebiotics and the use of fructooligosaccharides and other products. Momentito. And in different countries, these prebiotics, these oligosaccharides, have been added to infant formulas, generally without much research about them in general. And so there's an example recently in Australia and New Zealand in which the government basically forced them to take them off the market. And these had been, in fact, in use in Europe. These are permitted. FOS is fructooligosaccharides. Are in fact used throughout the European Union. They've been used throughout Europe for about almost 10 years with absolutely no problems ever associated with them has been described. Now, whether or not there's benefits, again, is an issue to be discussed. But the government basically of the food standard government of Australia and New Zealand said, well, you didn't tell us about it. We didn't agree to it. You can't use them. Take them off the market today. And they did. So there is a back and forth process, and I think the message is that there isn't any absolute way to decide, is something safe in an infant formula? Is it okay to add it to infant formula? But each country has to set its own standards for infant formula and decide what it will consider acceptable. Maybe if it's marketed in the United States or in Europe, it's acceptable for use in Colombia without testing here. But I'm not sure that that's true. And I think that, again, each country has to look at those data very carefully and be sure that the type of testing and the safety data are consistent with what they wish. La siguiente. Now I'm going to change to a different topic, but one that's important for us, which is bacterial contamination of infant formulas and the risks associated with that. And this is a topic that's gotten a lot of attention in the United States. There's a number of possible contaminants. The one that's gotten the most interest is the bacteria Enterobacter sakazaki. And this is from the initial large report that got a lot of attention in 2002 about a 1,300-gram baby who developed fever, tachycardia, and ultimately had meningitis associated with E. sakazaki and died. What turned out is that there are a number of babies in the nursery that had E. sakazaki colonization, and they identified it with the use of a specific powdered infant formula, Portigen, and that was heavily colonized. And in fact, they found it throughout that batch. Now this has garnered a tremendous amount of attention and interest, and led to lots of consternation and concern. A little bit about E. sakazaki. It's been known for a long time to be a contaminant of infant formulas. It was first implicated over 50 years ago. Worldwide, there's been at least 70 reported cases with 24 deaths of E. sakazaki, essentially all believed to be acquired via powdered infant formula. Okay? This is probably a vast underreporting of this entity. Full-term infants in the first month of life are at greatest risk of meningitis, and premature infants are at greatest risk of sepsis without meningitis. The reported mortality rate is extremely high. Now, we might imagine that what we feed infants is sterile, and that when we give an infant formula to a baby, by definition, it's sterile. That is not necessarily the case. In fact, powdered infant formulas cannot be completely sterilized, and they will tend to have a very tiny amount, sometimes, of bacterial contamination. Usually that doesn't cause a problem for infants. And Codex requirements and varying testing have shown that it's fairly common to have a small amount of bacteria, including E. sakazaki, in powdered infant formulas. So that means that what we must do is be very cautious about making sure that that bacteria doesn't multiply in the formula, and pay a lot of attention to how we administer formula. That is, we are not relieved of the responsibility for not allowing formula to sit for a long period of time, for not changing out tubing and things like that, on the assumption that if it starts with no bacteria can ever grow. La siguiente. There are currently varying proposed guidelines. There are no true official guidelines for the use of powdered infant formula in hospitals. First of all, we say that the use of powdered infant formula should have a clear indication. Personnel should use aseptic techniques in preparing powdered infant formula, washing their hands, using their gloves, etc. The use of sterile liquid formula is encouraged for healthy newborns. Liquid formulas are sterilized. They are completely sterile, whereas powdered formulas are not. Guidelines recommend that we use single-use bottles, nipples, etc.